Welcome to the Spine Nevada virtual seminar on the power of physical medicine and rehabilitation for sports and spine injuries. This is Molly Canady, Director of Integrated Marketing for Spine Nevada. We are excited to have all of you join us this evening. During tonight's virtual event, you'll hear from Dr. Andrew Hsu on the following topics: interventional treatments for sports and spine injuries, and non-surgical treatments for joint pain caused by arthritis. We'll have time at the end of Dr. Hsu's presentation for question and answer, so please submit your questions through the Q&A box. Without further delay, I'll turn the presentation over to Dr. Andrew Hsu.
Thank you for joining us today for our seminar. I'm going to be talking about the power of physical medicine and rehabilitation for sports and spine-related injuries. I am working at Spine Nevada as a physical medicine and rehabilitation expert, physician, and specialist in sports and spine injuries. So what is physical medicine rehabilitation? So you may have not heard about this specialty. You've heard of an orthopedic surgeon, you've heard of a neurosurgeon, but what is a physical medicine rehabilitation specialist? So we are doctors, MDs, go to medical school, we go to specialty training. It is a 4-year-long residency with a 1-year internal medicine internship built into that to learn how to take care of patients with complex medical conditions. We do inpatient medicine, and then we start working on musculoskeletal medicine. So that is doing sports medicine-related things, spine-related medicine, medicine-related treatments, and then also focusing on nerve conduction studies and EMGs. In my subspecialty, which is sports and spine medicine, I did a fellowship at the Columbia and Cornell New York Presbyterian Hospital in New York, where I learned how to treat more complex conditions, including spine and sports and musculoskeletal and orthopedic type injuries. So that is a 1-year fellowship in addition to what I did in residency, where I did my residency at University of Washington. And then I did a 3-year first practice stint over at the Medical College of Wisconsin, where I was attending physician. I taught residents, medical students, and I also treated patients. And then I found a job here at Spine Nevada. I've been here for 4 years now. Moved here in 2017, and I'm glad to treat all the patients that we've seen so far. And hopefully, if you're a new patient or is interested, hopefully we might be of service to you. So I want to talk about what is musculoskeletal. Some of you may or may not know this. Musculoskeletal is an all-encompassing term for muscle, tendon, skeleton. So basically, we can treat the muscle, bones, ligaments, tendons, and nerves. It is a very common issue because over 40 million visits of primary care physicians are musculoskeletal related. And so a lot of times, depending on the condition, if it's not resolving, we may get those referrals. And we're happy to see you and any of your friends and family that may have these kind of conditions. So musculoskeletal pain is very widespread. It's affecting probably half of American adults, 126.6 million is what is estimated. And you've heard of the term arthritis. Arthritis is a wear and tear of the joints. In addition, people may have other related issues, tendon-related issues or cartilage-related issues. And so everybody says, I have arthritis, but it can be very specific or it can be very broad. And over 51.8 million adults reportedly have arthritis. And a large portion of adults also suffer from neck or low back pain. So there's the arthritis can roll into neck and low back pain, and it's estimated to be about 75.7 million adults. And now this is based off of the new United States Bone and Joint Initiative. This is a government-funded study, and it's 2014. So we're here 7 years later, 2021, and we probably have more people with the conditions of, unfortunately, time and age and gravity. So what can PM&R do for you? We are in a multidisciplinary clinic here at Spine Nevada. Physical medicine rehabilitation is one of our specialties that I'm personally a specialist for. And we treat spine-related issues. We treat orthopedic-related issues, so low back pain, neck pain, mid-back pain, which is thoracic pain, You may have sciatica or radiating pain down the leg. You may have shoulder arthritis, shoulder pain, elbow pain, knee pain, wrist pain, and you kind of get the idea. Basically, pain in different areas of the body, joint pain, maybe even nerve pain, which we also treat as well. So I'm going to go through kind of a different set of mix of different issues to kind of give you a broad overview of what we do here at Spina Vetta, what a physical medicine rehabilitation specialist who's specializes either in interventional pain, interventional spine, sports medicine can do for you. Since our name is Spina Vetta, I wanted to talk about the spine initially. And so we see a lot of patients with back pain, and you may have back pain if you're listening to this, and you say, where's my back pain coming from? Well, did I have a back sprain or did I have something more involved? And so everybody says, oh, I have a herniated disc. Well, how bad is that disc? Is it mild, moderate? Is it severe? And that's where, it helps to evaluate you in person, look at your images, see your x-rays. So one person may tell you something, and then we may tell you something different. So hopefully we can figure it out for you. In some cases, yes, you may have a herniated disc. That's a very problematic problem. And we could try conservative treatments to more interventional treatments, which are involving injections, to surgery. And so we kind of bridge that spectrum for you and go over that in detail and make it focus for you. So just to go over the back, on the picture on the right, there is a picture of the spine, and it's sliced right thin. And you may or not, I don't know if you can see my mouse cursor, we got muscles, we got the joints, we got the disc, we got the nerves. And now this is a cartoon photo. When we get an MRI of your back, we can see all these structures, and then we can kind of see, is there something causing your symptoms from that MRI, okay? So I like to classify back pain in simplistic classification as 3 different problems: disc problem, a joint problem, which is the facetogenic, what you see on the screen there, and then other problems. So it could be a ligament problem, it could be a strain, like a muscle strain, or it's not so much the disc looks fine, the joints look fine, it's just the muscle's a little bit pulled one way or the other. And then you may have other symptoms along with that. You can have a radicular pain, which is the sciatic pain, when you feel like something shoots down the leg. It may go from the back down to the buttock, down to the leg, and then you may have problems walking, hurts to stand. Only thing that can relieve you is laying down or sitting down. You may have back and leg pain, so you have the pain from the joints, you have pain from the disc, and the pinching on the nerves. So it can be pretty broad. So we have the axial pain, which is just the back, the radicular pain, which is a pinching of the nerve type symptom, and then you have back and leg pain. So that's how we kind of classify it. And now, when we talk about the joints, as you get older, due to the effects of gravity, due to wear and tear, you're going to have arthritis of the joints sometimes. You may have inflammation of the joints. You may have gotten in a car accident and sprained the joints. And so the joints are hurting. They're hurting. And so we could do several things to help treat that. These joints are lined with cartilage, just like any other joint, like your knee joint, your shoulder joint. And they have a loose little capsule that holds together. So you can see on this picture, there's a little capsule that holds everything together. And that capsule can also get injured. Now we have a nerve that goes to that joint. So that nerve senses the pain and sends it down up to your spine, up to your brain, and you feel that as a pain sensation. So when this hurts, you may have pain when you're leaning back, rotating, so you're playing tennis, playing golf. You may feel that pain is a little bit more bothersome. You may have pain going down the stairs due to leaning back. And so you like to lean forward. You may lean forward on a shopping cart. You may lean forward on a table because it relieves your pain. You may want to sit down too. And sometimes those joints, they get really inflamed, like this picture right here on the right lower side. You're going to see like fluid, this white signal in the joint, kind of pushing out into the canal, which you see this arrow. And I don't know if you can see my cursor, but there is a fluid pocket right there. And that's pinching on the nerves inside the canal. That's called a facet joint cyst. And you're going to start getting sciatic pain. You're going to get pain shooting down the legs, okay? So the ways we figure this out, we get x-rays, see what's going on. Do you have arthritis of the joints? Do you have some loss of your disc height? You're getting a little bit shorter in the spine, which is unfortunately due to gravity and aging again. but that's okay. We kind of see how bad it is. We may want to get an MRI. We might want to see how bad the arthritis looks like, there's fluid or not. We may want to get a bone scan sometimes. That bone scan can kind of see if there's irregular uptake or basically increased metabolic activity or activity that signifies a joint as a problem, okay? And then treatment-wise, now, we don't always want to do interventional and aggressive treatment. We want to start off with the stuff that you think is more conservative, especially if you're new to all this and you haven't tried anything. We want to try physical therapy, home exercise, try some anti-inflammatory medications, try the ice, try the heat, may use some creams over the counter. There's so many creams nowadays. Now, we could talk all about that if you ever come in and we wanted to know about why lidocaine works, or why does diclofenac gel, why does menthol work, biofreeze work. They all work in different ways, but they're topical creams. And then we offer injections. Injections can numb up the nerves. You can put medicine in the joints, like with cortisone or steroid. That will help decrease the inflammation and hopefully help the pain. And that can last a while. So there's two roles for injections. One is to figure out where your pain is coming from. Number two is to help treat the pain too. And let's say the pain does come back. We're like, okay, we've been dealing with this for a while. We know where it's from. We know that your joints hurt. We're going to end up doing something a little bit more longer lasting, something like an ablation. So we call that radio frequency ablation, or RFA for short. So we need to do, insurance-wise, we need to do 2 blocks, or medial branch blocks or joint injections prior to the radio frequency ablation. And that's because insurance mandates that, but that's okay. Once we do that, we prove that that's where the pain's coming from. If we ablate that nerve, we can make your pain go away for quite a while, at least 6 months, maybe a year, maybe even 2 years. I've had patients come back after several years, and then they still have relief. So it just really depends on what your situation is. And we use X-ray guidance for those kind of procedures. And we're going to move on along that spectrum. We're going to talk about sciatica. Everybody says, I have sciatic pain. And that's very hard for a physician like myself to know exactly what that means. So I ask you specific details. Is it what do you mean by that? Where does the pain go? Does it go to your back, or does it go down your leg? How far down the leg does it go? So it really depends on which nerves are affected. It could be other joints causing that pain, like the sacroiliac joint, which is the joint of the pelvis. That's a very common mimicker of a true sciatic pain. And so if you have true sciatic pain, it's usually related to a nerve getting pinched. A nerve getting pinched in the spine. It could be from a herniated disc. It could be from the overgrowth of the joints, like we talked about before, including a cyst or a bone spur. And so those are things that we would try to tease out and figure out for you. So we have the disc herniations again. We have what's called central stenosis, or narrowing down the middle of the spine that can cause a pinched nerve. You got the foraminal narrowing. Foramen is where the nerves exit out of the spine. This is a slice down the middle of the spine, and we can see where this arrow is pointing to. That nerve is getting pinched because, one, there's a little bit of a slippage on the spine. There's a little bit of a bulge on the disc, and it's kind of squeezing that nerve in that hole, and then you might get some symptoms. And then sometimes things start to shift. You get that shift. That's called spondylolisthesis. We talked about that joint cyst right here. It's just another picture of one. This is a picture of a herniation. That there's a disc. This is a slice down the middle of the spine. You can see the disc there. The joint's also kind of bigger here, and so you're kind of pushing the nerves down. So you're going to get some pinching of the nerves and sciatic pain. Treatment options, again, we could be very conservative. We can start with medications. We can do physical therapy. We have excellent physical therapists that will put you through different types of exercises, try to relieve your pain. We'll do some manual treatments as well. And then we start talking about injections. And those will be epidural steroid type of injections. Now, all epidural steroid injections aren't created equal. If you've ever had a pregnancy, that really isn't a steroid injection. That's an epidural with numbing medicine. But they also go down the middle of the spine, whereas we really try to be specific and go for which nerve is getting pinched. We may try ice and heat, and then if the condition is severe and we've failed conservative treatments and there's an indication for surgery, then we refer you to neurosurgery and get you treated. Of course, if you have bowel bladder symptoms, your pain is so severe that you can't wait, then our surgeons will see you sooner and give you those recommendations as well. So this is just a picture of the different types of epidurals that we could do in the low back. In the middle is the internurameter. That's kind of a shotgun method. We do those sometimes. We try to be more specific when we can when we do the transforaminal. The other kind of shotgun method is if you have pain down below and we're trying to get the medicine up through your spine, is a caudal injection. We tend to do those less. So when do you want to come in when you have musculoskeletal pain or orthopedic pain? So we like to see patients who have acute or chronic injuries. You may have an overuse injury, training injury, weekend warrior injury. You want to join some race or marathon or a half marathon, and you sprained an ankle, or you have Achilles tendonitis, or you have a plantar fasciitis. We like to treat those as well. And then you have pain affecting daily life and functional activities. It just becomes more achy to get dressed, getting on and off the toilet, going to take care of your chores, mowing the lawn. Then you're probably having a hard time dealing with it. It's not getting better. Then you're not going to be able to do as much activity, and you're going to avoid things. And then the pain is just kind of cascades at that point. And it's usually recommended to get expert treatment at that point. You may have already failed physical therapy, or you're not even haven't tried it and you want to know what it's all about. We can definitely help you out with that as well. Definitely, if you have any symptoms of weakness, numbness, or pain in the arms or legs, you want to come in or get evaluated by a professional so we can evaluate to see how severe that is. So we talked a little bit about injections, and now I can't go through all of these because we have so many. The list is bigger than what actually I show on this picture, but it gives you an idea. We talked about joint injections, and we could do epidurals. We could also do plantar fascia bursa injections, which are like the rotator cuff bursa or the outside of the hip. It's called a greater trochanteric bursa. We do nerve stimulations. We do spinal cord stimulation. Those are like for people who may have neuropathy and people who have ongoing pain even after their lumbar surgery. There are conditions that we could treat with those kind of procedures. And then the last thing I was going to mention is the orthobiologic treatment. It's a very niche focus that we do, and we're all well trained in it, including myself, who's been doing this for quite a while. And we follow the FDA guidelines. So those are our main focus. Really is the platelet-rich plasma, bone marrow aspirate concentrate, and lacronized fat with lipogen. So common weekend warrior sports injuries that may happen include sprained ankle, just running, might have you're playing or you're doing something like soccer or basketball and you roll your ankle and it's not getting better. You try some conservative bracing, splinting, and you're worried. Come on in, we'll get it evaluated. You can get something called shin splints. Those are really tendon or microtears of the muscle injuries. It's kind of a broad term for your front of your shin hurting. And then IT band syndrome is very common. It's on the outside of your knee. You're pointing to the outside of the knee and wondering why is it hurt there. A lot of times it's tight. There may be some other things going on, fluid buildup, knee problems, biomechanical problems. And then tennis elbow could be related to tennis, but it's just on the outside of the elbow. It could be overuse, lifting a lot of weights, playing sports, contact sports, or just overuse. And so we like to treat that as well. Hamstring injuries are very common from kicking something or pivoting off. All of a sudden, you're making a shift change when you're running, or let's say you're playing basketball, you're guarding somebody. You can pull that. When you're making a large sprint, you have it. Even if you've been training or you haven't been training, and you all of a sudden make an explosive movement, that hamstring has a tendency to pull and tear, and you can injure that. And then knee injuries, very common. You could be skiing, you could be running, and it could be old injuries. Somebody hit you, or you got a car accident. You could have torn the ACL or the PCL and had a meniscal injury at the same time. Rotator cuff injuries are common with sports, but it's also common with just daily activities, working. Your shoulder hurts, not getting better, and you're getting pain when you lift over your head, putting on your shirt. You may want to come see us for that too. So let's talk a little bit about tendon injuries. It's probably one of the most common things that is not specifically said when you go and say, oh, my pain hurts here. Pain hurts on the outside of the hip. Oh, it hurts in my shoulder. It's most likely a tendon-related problem, at least initially, especially if you're younger. And then even when you're older, it starts to wear out, and then you get the tendon problems too. So very common in men and women. Gluteus medius, which is the outside of the hip, and gluteus minimus, which is outside of the hip. Those are muscle layers that form on the outside of the hip. The gluteus maximus is also the big gluteal muscle. So you have different bursas. So you have a greater trochanteric bursa, and then you have other glute minimum bursa. You have ischial bursa, which are your hamstring bursas. So these bursas are friction points. And then sometimes that friction buildup gets fluid and it becomes inflamed and irritated. Sometimes there's a micro tear in that. And we can see that. I use ultrasound a lot to evaluate things. I also use MRIs to evaluate things. And then we can kind of see how severe those things are. If you're a younger athlete, you jump a lot, or you're doing some kind of high jump or repetitive basketball type jumping, you may get patellar knee tendinopathy, or you might get a bursitis if you're kneeling down a lot. Achilles tendinopathy is pretty common too. Again, it's a lot of times it's an overuse injury, or it could be related to sporting activity like running. Tennis elbow, like I said before, could be related to tennis, but it could also be related to other types of overuse injuries. And all these types of injuries lead up to a significant portion of offices to primary care physicians, and then in our office as well. So why does the aging tendon get injured? Well, as unfortunately as we age, the metabolic activity of the cells decrease, the density of the cells decrease, and then the water content decreases. So really the tendon just gets stiffer. So if you've ever pulled up something that's stiff, it doesn't stretch as much. It's not as elastic. And then eventually it'll just tear. It'll lose its tensile strength, and you may have a tear. And depending on how bad the tear is, and maybe something that can be conservatively managed with therapy, to something that requires some orthobiologic treatment like PRP, to something that involves surgery. So we kind of have to evaluate that, but that's kind of how the spectrum works. So usually you come into our office, this is an example. If you're having a musculoskeletal problem, a joint-related problem, tendon-related problem, hip-related problem, I love to use ultrasound. This is an example of the different structures. It may look like a foreign body to you when you're looking at this right now, but ultimately we're trying to be very focused on when we're putting something like a medication treatment for that specific problem. So in this example, we're using a needle, guiding it from the skin, which is kind of up here, and kind of guiding it through, which you see the needle right here, through to between the muscle layers and the tendon layers. And in that tendon layer, this is where the greater trochanteric bursa would be to really help with bursitis, greater trochanteric bursitis, if you were going to use steroids. It's also a same location we would do something like a orthobiologic regenerative medicine approach, stimulating the tendon, putting it in the bursa, helping the tendons heal a little bit from the overuse injuries over the years. And then combining that, we focus on rehabilitation approach, which would be stretching, strengthening, different type of eccentric exercises depending on the injury. Eccentric, it just means it's just more of a technical term of how to put load on the muscle without the tendon, without injuring it, and also to improve biofeedback so that the cells inside that muscle and tendon hopefully heal. And then if you see our physical therapists, they'll sometimes use instrument-assisted soft tissue mobilization. So they're doing friction type treatments, mechanical treatments on a specific tendon to try to stimulate it so that it heals better. We may use dry needling techniques with our therapists as well to help stimulate that same tendon, same injuries, to stimulate more blood flow, the cells to be more active and hopefully heal. And then from our physical medicine rehabilitation approach, we're going to talk about, we could do injections without with lidocaine or needling, or we could do a steroid-based treatment, but there are some downsides. And then we talk about orthobiologics and regenerative medicine, which we'll discuss. So in the orthopedic world, there is a treatment gap, right? So if you're going to an urgent care, even some of our urgent care that we're affiliated with, you're found to have a severe musculoskeletal disorder or orthopedic injury. You've tried conservative management, maybe you tried bracing, maybe you tried physical therapy, and you're not ready for the surgery yet, but they want to send you to surgery, and you have things going on in your life. maybe you're moving, maybe it's you have to take care of somebody, maybe you have to go on a trip, and you're just not ready to face the risk of surgery, then there are roles of conservative treatment or less invasive treatment than a surgery, which would involve us. So, for instance, 3.6 million people in the U.S. Have knee problems alone, and then that's a $17 billion economic problem and burden on patients. And so, not everybody's willing to go through that. So, if we go through the traditional treatment with insurance, we may do a number of steroid injections, maybe we would do hyaluronic acid injections, and they work. They help treat the pain, but this may go on for some time. It doesn't necessarily help slow it down enough or reverse it enough as some of the newer therapies that we offer. And that's why we kind of mentioned things like lipogens and micronized fat and things like that. So major patient concerns about going total joint arthroplasty. So you get a bad knee and you're worried about it. Usually it's worried about complications, so worried about dying from it. You're worried about surgery could be risky. You can worry about the recovery from it. Most people do well, but not everybody does so, and we don't always have a crystal ball for that. And it's fully, once you get a knee replacement, which is an arthroplasty, it may not, if you're having a bad outcome, it may not be reversible. Now, that being said, we do have treatments in our armamentarium or our skill set to help treat people who have had post-knee joint replacement pain, and those involve things like knee, nerve blocks and ablation. And then worried about needing help from others. So you're recovering, you're using a walking stick, or maybe you're using a cane, and maybe even a walker, and you're worried about the recovery process from that. So here, and I bring in the line of, again, regenerative medicine, orthobiologic treatments. We have platelet-rich plasma therapy, we have bone marrow aspirate concentrate, and then we also do micronized fat therapy or adipose tissue, which is branded as lipogens in our case. So here is a picture of me doing an injection with the ultrasound, and the same ultrasound that I have behind me right here, and it's able to see all the fluid, joints, nerves, and we'll be able to put it in the right spot for you in a sterile fashion. So just a little bit about the history of orthobiologics. It's actually been going on for some time. It started in the 1930s with some famous people, and then using the guidance of prolotherapy, which we can also do for you. That's using involved dextrose and saline and maybe some lidocaine. And then PRP started to become more popular in about the 1990s. More research has been done, and now it's kind of the present and future for using regenerative medicine and orthobiologic treatments as a deterrent to having to have surgery. That's our idea. Now, platelet-rich plasma is involving concentrated platelets from one's own blood. We will draw about 120 milliliters of blood from your arm, and we spin it down. And we spin it down, we get from 100 milliliters, which is quite big, we get a little small amount, which is the platelet amount. That's a concentrated, high concentrated platelet amount. We try to get anywhere from 6 to 10x times the normal concentration that's in your blood, and we put that in a focused area. And now it may vary depending on how many things we're targeting. We can kind of tailor that to a specific problem. So PRP is actually, I don't want to confuse it with stem cell, because I don't like to use the word stem cell because it's a very big misnomer for what it really is. But platelet-rich plasma is your platelets. It has a lot of growth factors, and it helps stimulate healing in tendon, ligaments, and joint-related injuries. So the platelets have growth factors, and those growth factors will make contact, injure cartilage, and injure meniscus. They release their growth factors, and they help stimulate those injured areas to hopefully heal, be less inflamed, and feel better. We're currently using this Excel PRP kit, the specialized kit that's known to concentrate the platelets at a higher amount, and it's a quality system. We also have the Pure BMC2 system for patients who are in the know about these different, and these aren't like the the kits that you may get from a dermatology practice, or it's something a higher level than a lot of practices provide. Now, most individuals will not be able to understand all the differences, so that may be one of the reasons why price points are actually different when you're getting therapy. Number one, you got expertise. Number two, you got the quality of the system that you're using, and then three is how are you delivering that system. So that's one of the questions that I'm trying to answer. I'm sure somebody will bring it back up at the end. But now PRP has a lot of growth factors. Now these growth factors help stimulate a healing response. We call there's different types of ones. These are just a few of them. Ones that all of these are actually really important. But one thing that people really focus on are the regeneration, the modeling, bone remodeling, inflammation. It's like that's what you see right in here. So these platelets, they contact the site of injury, they release these growth factors, and they stimulate the existing cells in your system at that location to hopefully stimulate a healing response. Now, PRP has been researched over the past decade or 2 decades, and there's just more and more studies, right? Every little problem gets researched, and so that's great because hopefully we'll find new indications. Hopefully one of these days insurance will pay for some of these treatment options. But you can see over 7,000 references in 2013 alone. And then I did this search today, and now I just typed in, you can go on PubMed, that's a government organization for publications that people publish papers that they've researched, studies that they've researched on, or aggregate, including we call meta-analysis, which are review articles on specific topics. And you type in just PRP, and you'll come up with at least 1,300 results. And you can see it's just taken off over from 1975 or 1976 to 2021, and it's a topic of interest. It's something that people want to know the work for them. So there are a number of studies. I won't go into each of these individually, but we have different conditions. And so we have lateral elbow, we got the greater throat cancer, we got the hip, we got the knee, and all these studies have shown that there is some benefit from all this. So again, from the outside of the hip, gluteal tendinopathy, there's one study that showed 82% of the PRP group improved, whereas only 56% improved in the cortisone group. Now, cortisone works really well. When I do it on the ultrasound guidance, so my success rates are a little bit higher than this, but I think PRP has a longer lasting benefit than what cortisone would do on its own. Now, in addition, cortisone repetitively on injured tendons, there's always the risk, and I always bring it up, that does weaken the tendon. It can get injured, it can tear, and then it becomes a problematic issue. So sometimes we have to weigh those risks and benefits when we do regular type cortisone injections. Lateral epicondylitis or epicondylopathy, big technical terms for tennis elbow. Basically, PRP injections show better improvement compared to corticosteroids. Now, both of them help. PRP tended to last longer and help more. So, and other tendon problems. Now, this is a study that kind of reviewed multiple studies. As you can see here, 40 plus 29% of subjects had greater than moderate relief. Okay, so that's almost 80%, 70%. And then if you include the moderate category, it's like 80%. So that's pretty high success rate given a specific problem that's resistant to a prior treatment. And those will vary from any kind of orthopedic related issues that we've discussed, elbow, knee, hamstring kind of issues. Okay. Now going beyond that, now we're talking about more powerful treatments. The reason why we say it's more powerful because there's actual live cells in there, and it's not just and it has a higher concentration of growth factors. And so something like bone marrow aspirate concentrate, we call that BMAC. Now we get this bone marrow from the iliac crest, from the outside of the pelvis, where it's typically drawn because that's one of the highest concentration of bone marrow that you can get. And now we process that similar to how PRP is processed, and then we inject it in specific issues. So when people always ask me, where would I put that BMAC? I usually try to keep it in an enclosed space like a joint because it has more time to work in that joint. It's not free flowing, doesn't get outside the joint, and it can interact with cartilage cells or the meniscal cells, depending on, say, if it's a knee, and try to provide some benefit from that. whereas I can do it also on rotator cuff tendons and other tendon-related issues, or even in the spine, where we do it in the joints in the spine, or even in the disc of the spine. They can be very helpful too. But we want to usually, because of the cost factor and because of the concentrate factor, I like to try to keep it to a specific joint if possible. Now, along those lines, another alternative would be lipogens or micronized fat. Micronized fat is basically fat that's processed so that the cells can be in contact with other cells and stimulate the existing cells to improve a healing response. And so in fat, there is actually stem cells in there, and they lie around the vessels and in between the fat cells, and they release growth factors just like bone marrow releases growth factors and PRP releases growth factors, and it's a higher concentration and volume based on the type of cell it is. They're very supportive. Supportive cells in there called the adipocytes or the fat cells, along with the mesenchymal cells. They kind of interact together, and then you're putting it in an injured tissue, and because of the structure of the fat, it does last a little bit longer inside a specific area if you're putting it in a joint. It can also fill a defect. Say if you have an Achilles tear or a rotator cuff tear, and you're trying to be very specific where you're going to put it. It has a longer half-life and being able to stay there and hopefully stimulate a healing response. So how does that work? So usually for lipogens, we actually get it from the flank, or we get it from an area where fat is usually collected, like the thigh or the abdomen. We numb it up with anesthetic, and then we use a system of a needle approach it's actually a blood type needle to aspirate or take out the fat, and then we process it, which you see as number 2, and we're processing it with saline and sterile saline, so everything's sterile in this process, everything's clean. It just gets rid of some of the things that aren't really going to help, and then we filter it out. We got the micronized fat right here. You see the needle, and usually you don't need a whole bunch. Depending on the condition, and you're putting in injured places like rotator cuff, partial rotator cuff tears, patellar tendon tears, labral tears, meniscal tears, arthritis of the knee, and it helps provide that structural filling as well as the stimulation of the surrounding structures, the tendons that are injured, the cartilage that's injured to hopefully heal and give you relief and less inflammation. So that's really the goal behind those. Now, the reason why we only target these 3 different types of treatments at our practice is we're really meeting the FDA guidelines. There's a clear, you can Google this, or you can go on the internet, you can type in CFR 2021 FDA guidelines, and you'll see that there are specific rules. We don't want to more than minimally manipulate a structure or cell, and that's what we do, and that's how we follow those guidelines. Now, you've heard of stem cells, and there's a reason why we don't just say we offer stem cell treatment, because there is the FDA has warned about it. It could be legitimate, or it could be something that's a little bit marketed toward something that's a little bit false marketing. There are technically, when you're administering anything that's outside your body, if it's not your own body, has to go through a biologic FDA approval. It's called the BLA process. And a lot of companies don't have the ability to do that for monetary reasons, time-related reasons. And there's a reason why it takes a long time to get drugs approved on the market. And yet they're bypassing it and they're offering it. And we really don't know about the safety or the efficacy or how it works. So it's something that we have to be careful of as a provider, as an honest provider. And then as someone, I want to educate you as an individual to look into this. So amniotic tissue products now, these have been mentioned multiple times on different forums and out there on the internet. And you have to be careful because they don't actually have been shown. They actually have not been shown to contain living cells. They've tested this in the laboratory. They do have growth factors, so they may be of some benefit. They are shown to heal some wounds when they're used as a wound type of healing treatment. But there has been some studies that show that there's actually less growth factors than that of what you can get with PRP, which is from your own blood. And most people don't have any interaction with their own blood. So that's a very positive aspect of it. So The FDA will not allow any amniotic tissue that does not have the proper BLA to market as a stem cell product of any kind. If you hear that they are, then they're violating the FDA. So be careful of that. And then there are sometimes mislabeling of people doing stem cell interventions. Again, I would recommend being careful about this. Not everybody is a physician, and not everybody is a fellowship-trained physician in this area. 66% are physicians, but 34%, that's one-third, have been shown to be not necessarily physicians. They may be providers. It could be anything depending on the state law, from other specialty, other types of providers other than doctors who went to medical school. And then even then, not everybody got trained to do more invasive interventions that we could do here. So again, it's just more of an advice to try to be cautious of who's providing the service that you're looking for. This is just to bring up a recent incident. This was published earlier this year, about assistant physician who did not go to residency, was involved in politics and falsely promoted and got in trouble with the FDA and also beyond that. And now there's a lot of other actors out there who may not be investigated, so you do have to do your own due diligence. If you were to come see our clinic and you were interested in these types of therapies, now, if you were to see me, as anybody who knows me as a person, I never push this kind of stuff, these type of treatments. I talk about the different spectrum of treatments, just like we talked about physical therapy, we talked about interventional procedures involving what's covered by insurance, and then even surgery, and then alternatively, which is more experimental, but there's a lot of research behind it, is the orthobiologic treatments. And so we want to be fair and honest with you. The good thing is that FDA, the products that we use are FDA cleared technology. They're compliant with the FDA guidance, that CFR 21, Title 21 that I mentioned before. There are a lot of research studies on this. Most of the time, it can be a one-time procedure. You can opt to do more, depending on how you deal with these kind of things. And it's a very tailored approach. Depending on the situation, we may be able to inject more than one site. It just depends, again, on what the problem is, how many different problems there are related to that. And then the downtime is relatively short compared to something like surgery. You may have a few days of pain or discomfort. Usually it doesn't last more than a week. It's actually quite accepted at the most academic medical centers doing this, and that's how we base our training and our treatment. We're using the same kind of therapies that they provide at some of the bigger name hospitals that you may have heard of on this list. And so some final thoughts. Musculoskeletal and orthopedic pain is everywhere, prevalent. There's a lot of different problems. You can have neck pain to back pain to orthopedic pain and musculoskeletal pain. Your knee hurts, your shoulder hurts, your ankle hurts, your back hurts. And so we want to be able to tailor the treatment to you as an individual. It may be different than your friend or your family member who has similar types of pain, but when we look and delve into it a little bit more detailed, we find a different issue altogether. So really, one size does not fit all. We do our best to tailor treatment to your specific condition and scenario. Spine Nevada, where I work, offers a diverse array of treatments to help manage your condition, and we provide the full spectrum of treatments, including orthobiologics.